So we are with Professor Faiez Zannad. Thank you so much for joining us today to discuss about the European Society of Cardiology Congress, virtually organized this year due to pandemics. And we'll discuss today about the EMPA-Reduced study. We'll try to identify what are the key messages coming from this study, what are the clinical implications, and what we can expect for the future. So, first question, the Professor Faiez Zannad. At the beginning of the Congress, the announcer said that the European Society of Cardiology Congress has begun and bang. And the bang actually was the EMPA-Reduced. A big start for the Congress and big results actually for coming from this study. Could you provide us some sentences, some conclusions?
Sure. Well, thank you very much for the invitation. I'm really pleased to share with you the highlights of the results, and now they are public. It have been presented at the ESC, and there have been two publications, which is absolutely exceptional. We have the main publication in the New England Journal of Medicine, and a day later we have the meta-analysis of the two trials in this space with heart failure with reduced ejection fraction. So EMPA-Reduced is a trial with empagliflozin in heart failure patients with reduced ejection fraction with and without diabetes. And this is very important to keep in mind because it's no longer a diabetes trial, it's a heart failure trial. And patients were slightly more severe than in DAPA-HF, and the results are very, very consistent and really powerful. The three pre-specified endpoints, the primary and the secondary hierarchical classified endpoint were met with a very significant decrease in the combined endpoint of heart failure hospitalization and cardiovascular death. There was also a very highly significant decrease in the total number of hospitalizations. This means the first and repeat, because these people keep getting back to the hospital, and therefore the totality burden of hospitalization was decreased. And the trial was actually cardiac, but also a renal outcome trial. And we had pre-specified the declining renal function, which was measured in multiple ways. One way was the slope of decline of eGFR, which is inexorable decline in patient on conventional therapy. And with empagliflozin, the slope was slower, so that the progression of kidney disease was slowed by empagliflozin. And we have also pre-specified the composite endpoint of renal death, transplantation of renal and dialysis, and the larger contributor was the profound and sustained decline in GFR below 50, above 50% of decline. And this was dramatically modified by the medication with a very profound prevention of these severe renal outcomes.
We've seen that the number needed to treat in the study was just 19, which is very low. I would like to ask you to enter into more details and what are the implications coming from this very, very small number.
Sure. Well, the implication is that this class of medication is going to be there to stay, and this is really a game changer. So now we have 4 medication that we would like to have all our heart failure patients on. And this is beta blockers, RAS inhibitors soon to be replaced by ARNIs, and mineralocorticoid receptor antagonists. And now the 4th one is SGLT2 inhibitors with empagliflozin and dapagliflozin showing very consistent results. One very important point for implication is that empagliflozin is prescribed at 1 dose. No need for up titration, right? And by the way, because the safety was great and there was no concern about worsening renal function, hypotension, hypoglycemia, or hyperkalemia, all these elements which are really the main deterrent of up titration of RASI, for example, there is no concern about this in SGLT2 inhibitors. So we anticipate that the implementation of the result of EMPA-Reduced would be straightforward. 1 dose for everybody and no need for up titration.
What do you consider would be the implication in clinical practice? You mentioned that the benefits are clear also for diabetic and non-diabetic patients. And what are your expectations regarding the way the clinical practice will change and the benefits for the patients with cardiac failure coming from this study?
Absolutely. We really anticipate that these medications are going to be extremely useful for the patient because they are going to be very easy to handle, to initiate, and very easy to keep patient on medication. There would be very few cases of discontinuation because safety was really excellent. And because these medications have a combined benefit on cardiovascular heart failure outcomes, but also renal outcomes. And in this trial, patients were enrolled with EGFR as low as 20 milliliters per minute. This means across a very wide spectrum of heart failure severity and very wide spectrum of renal function, these medications are going to be extremely well tolerated, very beneficial, and therefore we expect that these are going to be very much simple to use and hopefully very beneficial to heart failure patients.
In this study, EMPA-Reduced, we have seen that patients had a more advanced but stable heart failure. And my question is, how do these selection criteria overlap the general heart failure population, and if this impacted the study outcomes?
Well, it's a very important point. EMPA-Reduced is not in isolation. It is a trial duplicating the result of DAPA-HF, but also we have seen so much benefit, heart failure outcomes in diabetes trials, whether it is EMPA-Reg outcome, DECLARE, CANVAS. So all these taken together, and this is what we call the totality of evidence, are very strong and robust demonstration of the benefit of this class of drug in heart failure across a very large spectrum of heart failure phenotypes in the reduced ejection fraction. We still have to wait until next year in order to know about heart failure with preserved ejection fraction, but at least in patients at risk of developing heart failure with diabetes, and this is the previous diabetes trials, but also in patients with prevalent symptomatic heart failure and reduced ejection fraction, whether they have diabetes or no diabetes, and across a very large spectrum of disease and of CKD, this medication is going to be very much useful.
And my last question, looking into the future, I don't know, looking into the next year and future studies with empagliflozin, what we should expect more from this medicine?
Well, empagliflozin is undergoing lots of other trials. EMPA-Reduced was one of the first in heart failure space. You know that there is EMPA-Kidney, which is similar to DAPA-CKD. Hopefully, we will be able to reproduce same kind of fantastic results. And we have the twin trial of EMPA-Reduced, which is EMPA-Preserved. And this is going to be the first trial in heart failure with preserved ejection fraction with an SGLT2 inhibitor. And this is going to be delivered in 1 year. So the future is bright. We need to keep tuned, and we will have more to come. And from EMPA-Reduced, we have many more data and many more publications which are going to be soon to be published. We have a biobank where we will explore biomarkers in order to better understand also how this class of medication works, so mechanistic insight. So there are much more to come.
Professor Faiez Zannad, thank you so much for all the explanations and for your presence at the Raportul de Gardă.
My pleasure.